Hi, it's Kai Hermann again. I'm a radiologist from Berlin, and I'm going to present case number 29 of the ASAS Online Case Library. The medical history and clinical examination you can read for yourself, but in brief, this is a 32-year-old male patient who showed up actually in the emergency department due to acute low back pain. On history, there was some slowly rising back pain already 3 to 4 years ago, but the patient did not further work that up at that time. There is some enthesitis tender points at the right spina iliaca posterior superior. And looking at the lab findings, there are no signs of active inflammation. There's negative CRP and ESR. There's also no laboratory signs of infection, and HLE-B27 was tested negative. Let's come to the images, and first we start with the X-ray of the pelvis. As you can see here, it's written here, it's a Ferguson view. The Ferguson view can always be recognized by the strange shape of the hips and the enlarged symphysis. So you see it's an oblique X-ray focusing on the sacroiliac joint, and when we have a look here, we can see that the joint contour looks normal. There's no erosion on both sides. Maybe there is some sclerosis here on the left side, maybe also a little bit on the right side, but there's also a little bit of sclerosis physiologically at these areas, so you cannot be sure. And down here there's maybe a little bit of irregularity, but it's also not clearly seen at this point. Looking at the lumbar spine, we can clearly see there is some scoliosis to the right side. And here again, we have another option to approach the sacroiliac joints. This is now the AP view, so the normal appearance of the pelvis. And if we enlarge here to the sacroiliac joints, we can see there is some sclerosis to be seen lower down. So we were quite correct in our Ferguson view analysis, and maybe there's some irregularity of the joint contour here on the left, but I don't think it is the same on the right. Looking at the lateral view of the lumbar spine, I think what is showing up most prominently is this defect here at the end plate of L3. So let's enlarge that a bit. So that is the upper end plate of L3, and we have a defect over here close to the corner of the vertebral body. Maybe there's also some sclerosis surrounding it, and this is exactly what was described by Dr. Romanus back then, and this is in corner erosion, which we now call the Romanus defect or the Romanus lesion. Patient was later on transferred to MRI, and we performed MRI of the sacroiliac joints and also of the lumbar spine. Let's have a look at the stir sequence first. If you approach the joint from the anterior slices to the posterior, here you see some vessels in the pelvis, seeing here. So this is a good sign that this is the anterior part of the joint, and the joint is barely visible here at this point, but you see some sclerosis, some osteitis or bone marrow edema already here in these very anterior slices. And as you further approach into the joint, you can see there is bone marrow edema adjacent to both parts of the right sacroiliac joint, and also there's faint bone marrow edema on the left sacroiliac joint, and this bone marrow edema gets more pronounced as we further advance into the joint, so we can see the majority of inflammatory load is here in the lower part of the sacral bone next to the left and also to the right sacroiliac joint. Looking at T1, we check for erosions and fat lesions. So you see what's predominant here is this dark area next to the joint. So if you make it brighter, you can see there is this high signal here, intermediate signal, which is the cartilage in fact, and this dark band next to this joint contour is the sclerosis of the bone that we could also see on the X-ray, but here we see the full extent of the sclerosis, and we might assume that there are some smaller erosions. For instance, if you look here, there might be some irregularity of the joint contour, but due to the sclerosis, this is not very clearly seen. You might also wonder whether this small area here is already fat metaplasia in an erosion cavity, which we call backfill, but it's only a very faint finding. But I think the most interesting findings can be seen on the lumbar spine in this patient. And this is the T1 weighted MRI sequence. It's clearly written here in the corner, but to repeat it a bit, you can always detect a T1 weighted scan by looking at the cerebrospinal fluid, which is dark, the nucleus pulposus, which is dark, and the fat component in the subcutaneous area, which is bright. So this is a T1 weighted scan, and you see structural lesions of the spine in this sequence usually. And in fact, also this patient has structural lesions. There are these bright lesions here in the L3 upper end plate, and we have this dark lesion here in the L4 upper end plate. So if you remember, on the X-ray there was this erosion at the upper L3 level, so this is around this area. So you can also appreciate it here again. So there is this erosion surrounded by fat metaplasia, and here again it looks like we have another erosion at the L2 end plate, but we did not see it on the X-ray. We will shortly compare it again, and we have this dark appearance here on T1, and also here we have a dark appearance of the bone marrow. So if you see some dark lesion on T1, you would always like to check on a T2 weighted scan or a stir scan. So we see here the upper L3 is bright, but we also see upper L2 end plate bright and also the L1 end plate bright. So we see on a T2 weighted sequence, we have 3 vertebrae with bright end plate lesions. If we compare it with the T1, then we can see that the L1 and L2 areas are dark on T1 while the L3 area stays bright. So this shows us that this is a fatty lesion, and this is an inflammatory lesion where is only fluid here to be seen on T2. And of course, it's much easier to compare it directly to a stir sequence. So if we replace the T1 with the stir sequence and compare it again, we can see that on the stir sequence we clearly see the inflammatory lesions in T1 and T2, and the fat lesion is showing up here as a dark area. So we would not rather look at the stir for fat, but rather look at the T1, which is shown shortly. Okay, I think what's worthwhile is comparing the the X-ray with the spinal lesions. So if you look here again at the T1 weighted area, T1 weighted sequence, you can see that there is this erosion and sclerosis in the L3, and we see the fat metaplasia and erosion here. And there's also an erosion here, which we see by the defect in the end plate, which is not at all showing up on the X-ray, and also this lesion here, which might have a small erosion, is not showing up there. So this is a very interesting observation that you see. You have here a patient who is HLEB27 negative and has clinically not a very clear picture of axial spondyloarthritis. Of course, there are some hints for that, and there is X-ray not very striking on the pelvis, and with only one lesion at the lumbar spine. And there are showing up a lot of lesions both at the sacroiliac joints and the spine on this MRI, which underlines the value of MRI diagnosis in patients with axial spondyloarthritis. As you study this case on your own, of course, you already know that you can highlight the important lesions with this overlay button. So here we have marked the erosions again, both on MRI and on X-ray. And if you compare the T1 and the STIR and switch on the overlays, you can also nicely see the different appearance of these lesions in the different sequences. So I hope you had fun watching this video and learning about spinal lesions in this patient. And I'm sure you will be subscribed already to the ASAS Online Case Library, and we will see us next time when I present the next case. See you and bye-bye.